Okay, so we're going to continue with our lesson. We're going to be in Module 3, and you can see for today's agenda is person-centered care and decision-making, advanced planning, empowerment, resident assessment and care plans, resident councils, family councils, and the conclusion. Now, this is just a portion. You have probably already we've probably gone over person-centered care for our first hour. So feel free at any part of this just to advance the recording and jump in where you need to start. So I'm going to start from the beginning, but again, like I said, just move it forward to the part where which was not covered in class, and you can just kind of pick it up from there. So let's get into this. Person-centered care. Let's start with that first. So first, our learning objectives, person-centered care, advanced planning and decision-making and authority, the importance of empowerment, the assessment and care plans, resident council, and family council. So we'll go ahead with person-centered care. Okay, so person-centered care is a process for selecting, organizing the services and supports that older adults and persons with disability may need to live their lives to the fullest potential. So person-centered care places the decision-making and self-determination in the hands of the individual residents to express choices and preferences about their care and day-to-day activities to the extent maximum as possible. So areas in which a person-centered care can be individualized include these right here: activities, bathing, care, death and dying, dining, dressing, community involvement, medication administration, relationship, staff assignments, and work. So you're going to now see a presentation on person-centered care and what that is, and then we'll continue from here. So I'm just going to take myself off of the camera for a minute. I'm queuing it up.
Person-centered care recognizes that a person is the most important part of their care. That's why person-centered care encourages nursing home staff to partner with a resident to make decisions about the person's care. By building relationships and thinking people first, staff treat residents with the respect they deserve. Mr. Davis has dementia. When certified nurse aide Sarah Jones tells a new nurse about Mr. Davis, she puts the person first, then mentions his health. Sarah says Mr. Davis has dementia. She does not call Mr. Davis confused. By avoiding derogatory words and putting Mr. Davis first, Sarah emphasizes Mr. Davis's value and respects him as a person. Sarah avoids creating labels or nicknames for Mr. Davis. She does not call Mr. Davis a walker or a talker. Instead, Sarah tells coworkers that Mr. Davis enjoys walking and likes to talk. When in doubt, Sarah asks a resident how they like to describe themselves and uses the language they prefer. When staff put residents first in their language, they recognize the whole person and don't let disabilities define a resident.
Okay, so that is our film on person-centered care. And we'll get right back into this. Okay, so we talked about that. And we'll go back into our presentation. Okay, so let me get the notes up here. Okay, so as it said, that film from Texas Health and Human Services puts it together about person-centered care. Person-centered care uses neutral language, not describe the person as lacking, such as June had a stroke, but June is a victim of stroke. And person-centered care language does not use labels like feeders or honey or sweetie, but they instead call the resident by their name and by their choice. So moving on, we're going to talk about person-centered care based in law. Okay, so the awareness of and requirements to person-centered care or planning are growing. Federal regulations for nursing facilities and for Medicaid-funded long-term care services supports and requires person-centered care and planning. Brief examples from federal requirements are below. Person-centered care and resident rights will be discussed in more detail in the next module. The first federal law to refer to person-centered care is the Omnibus Budget Reconciliation Act of 1987, also known as the Nursing Home Reform Act. While the primary goal of the OBRA 87 is to improve the quality of care and to provide residents and establish uniform standards of nursing homes, the Act also requires nursing homes to promote physical, mental, psychosocial well-being of the resident and promote quality of life, choice, self-determination, and rights of each resident. Additionally, OBRA 87 required state and federal governments to evaluate whether each resident is receiving care that promotes the highest practical well-being. It's also to ensure facility compliance with resident rights and quality of life. Person-centered care is a requirement of the federal nursing facility regulations. The regulations are defined as follows. Quote, person-centered care means to focus on the resident as the locus of control and support the resident in their own choices and having control over their daily lives. So who gets to decide when it comes to person-centered care? It's the resident. So this personal direction for quality of life, I am going to send that as part of your resource supplement. It's just a tool to help people to decide, residents to decide what's really important to them. And it has an outline that they can fill out so they can start thinking about what that looks like to them. So I am going to send that resource to you, and so you can have it, you can give it out to your residents, even for family and friends. It might become very helpful. So you'll be getting this in your resource email. Okay, let's talk about traditional care and person-centered care. So facilities set in traditional care, facilities that operate using this model are more institutional. The focus is usually on what works for the business, what works for the facility. Management makes most or of the decisions. The daily schedules accommodate staff preferences and the facility's routines. Facilities are truly practicing person-centered care, make decisions based on the residents' preference in their care and their routines. The chart below illustrates some of the differences between the traditional institutional model of care and person-centered care, so as you can see here. So, okay, so it is up to the Ombudsman. It is the role of the Ombudsman program to advocate for resident rights and person-centered care, empowering residents to direct their care in their life. How does the long-term care ombudsman program promote resident-centered care? This is accomplished through educating and empowering residents, modeling person-centered care communication, and promoting resident participation in the care plan process. Educate and empower. A key responsibility of the Ombudsman program is to inform individuals about resident rights. Representatives continually educate residents, family members, staff members, and the public by providing information about resident rights, and person-centered care. Representatives empower residents to voice their concern and be part of the complaint resolution process to the extent or desired. The Ombudsman program also serves as a resource to staff by sharing promising practices and providing training on resident rights and person-centered care. Many Ombudsman programs are involved in local coalitions and initiatives in support of culture change and person-centered care. Then we model person-centered behavior. Representatives model how to work and communicate with residents. Representatives always treat residents with dignity and respect. For example, by following the direction of the resident and involving the resident throughout the problem solving process to the extent of possible or desired, the Ombudsman program models person-centered care to facility staff, family members, and others. Third one is that we promote resident involvement and care plan processes. So representatives support resident participation during the care plan process to ensure the residents' needs and preferences are heard. We incorporate and we implement this. And so the care plan process is discussed in more detail in this model. So we're going to go ahead and move on to section 3, which is the decision-making capacity and understanding that. Okay, so this is maybe a little bit challenging for those who are not, they haven't worked a lot with judges or POAs or as case managers, but we'll get through it. We just want to hit the basics of understanding what capacity is all about. And as you can see here in the model, we have no decisional capacity to some decisional capacity to decisional capacity. So what we're talking about is a spectrum, understanding the spectrum. Capacity, let me give the definition, is the ability to make and to communicate an informed choice. There is no simple test for capacity. Often understanding the residents' personal values or their preferences or their goals can assist in understanding their capacity to make decisions. Capacity is issue specific. It's a spectrum. It's transient. The first question is capacity to decide what. So different types of decisions require varying levels of memory and distinct cognitive skills. The memory needed depends on how relevant past information is to the choice at hand. For example, very little memory is needed to decide what to wear or what to eat today. Different decisions require different cognitive skills, such as calculations and comparisons and organizing data. So capacity is a spectrum. The ability to understand and make choices is not an off and on function. Capacity varies in subtle degrees from no to very low levels of understanding to the ability to understand and to make decisions on very sophisticated and complex issues. Capacity is affected by health, pain, medication, illness, or injury. Capacity can be developed by learning and experience, and it can decrease with illness or injury. As these factors change, capacity can increase, it can decrease, and return. So So as we have here, as a resident advocate, it is a core program responsibility to empower residents and encourage others to realize the extent of the residents' decision-making abilities. When you are unsure of a resident's decision-making capacity, some questions to consider include, does the resident understand the information? Can the resident relate to the information to their situation? Does the resident understand the possible outcomes of their decision? Can the resident retain the information long enough to make a decision? And can the resident communicate their decision in some way? Okay, so representatives empower residents and encourage others to realize the extent of the residents' decision-making abilities. If residents' ability to make decision is still not clear, or the status, excuse me, the status of the resident's capacity is uncertain, you may consider the following questions. You can ask the resident for permission to speak with their representative, someone like a POA. You can follow state program policies and procedures for working with the resident when capacity is unclear, and you always want to consult your supervisor for guidance. You want to use language in a manner that the resident understands, discuss choices and outcomes. Let the resident talk to the resident and to a reliable person. And you want to give the resident also the time and enough time to consider what their options are. So decision-making applies to all areas, which includes health, legal, financial, daily life, visitors. So regardless of the capacity, residents make their own decisions every day about how they want to spend their time. It can be something really simple. They may not know what year it is, but they may be able to communicate if they want to see a specific family member or have a visit, or what activities they like, or what foods they like. So residents may not be able to manage their finances, but they can determine who they want to manage their finances. So the goal of the Ombudsman program is to focus on the resident and their wishes, even if the resident is not able to make all their decisions. For example, a resident may determine their daily routine, or go out and visit with friends, or spend pocket money, or decisions that are made up of individual acting, like who they want for their durable power of attorney. Can communicate with the residents and assume that they can make their own decision. You always want to start with that first. So to empower residents, pardon that, I'm having some reminders go off on my calendar. To empower residents to exercise their rights to choose and to participate in their care to the extent as much as possible. So the Arizona, we have here our information on advanced planning. You are going to be getting a copy of that to become familiar with that. And in that, this is a very important advanced planning directive, because it tells us what exactly the resident wants. So I'm going to make sure you get a copy of this and you can review it. So the Patient Self-Determination Act requires that most hospitals and nursing facilities, home health agency, hospice programs, and HMOs to provide information on advanced directives. The PSDA strengthens resident rights to be informed of and to establish their advanced directives. Advanced care planning involves learning about the type of decisions that might need to be made, and considering those decisions ahead of time, and then letting others know, whether it be family members, care providers, about their preferences. These preferences are often put into an advance directive, which is a legal document that goes into effect only if an individual is incapacitated and unable to speak for themselves. So we're going to take a few minutes to go into these advanced planning and third-party decision makers. So, as you can see here, per American Bar Association, a healthcare advance directive is the primary tool for any healthcare decision made on behalf of an individual, should that individual become incapacitated. Quote, healthcare advance directive is the general term for any written statement someone makes while competent concerning their future healthcare wishes. Formal advance directives included living will, healthcare power of attorney. Other types of advanced care directives involve discussions with person's doctor, and these are written in the form of a medical order. So what we have here is different types. We have the DNR, which is a do not resuscitate. We have cardiopulmonary directive, which is a CPR. Healthcare provider advanced directives may have other terms, CPR, DNR. So this is sort of the language that's used. This type of medical order is signed by a doctor and the patient, and instructs providers on the patient's desire about resuscitation if the person's heart or they stop breathing. Some states call this directive an out of hospital DNR. This form for this, who must sign it, it varies from state to state. Then we have the portable medical orders, and they're often referred to as a POST. However, states use other words, another acronym. So POST, POLST, means practitioner, provider, physician orders for life-sustaining treatment. And then there's the POST, the physician's order for a scope of treatment. There is also a MOLST, MOLST, medical order for life-sustaining treatment, and most medical orders for scope of treatment, MOST. So a PULSE form tells healthcare providers what treatment and the individual wants and the individual's goals of care. Even if transferring from the hospital to a nursing facility or a hospice or another setting, it points to remember about these PULSE is that PULSE is for people who are seriously ill or have advanced frailty. It is a form that is signed by both the patient and, in many states, by the healthcare representative, if the patient is not unable to do so, and the doctor as well. So most important is that it involves a discussion between the doctor and the patient. So why is it important to LTCOP? The CPR directive and the POST are documents that explain the resident's wishes. So when a resident is unable to communicate their wishes and there's a question about end-of-life decisions, these directives are to the medical profession will help determine what actions the resident wants or does not want. These are just one type of medical records of a representative of the office may need to review during a complaint investigation. So Arizona has its own POST. Again, as I said, you'll be receiving that information in an email through your resources. Okay, so the advanced directives, discussed include information about specific documents and physician orders, and expresses an individual's preferences for healthcare treatment. Some advance directives allow for individuals to name someone else to make that decision on their behalf. Okay, so the Ombudsman program follows the direction of the resident. However, there are residents who lack the ability to communicate their wishes, needs, and preferences. Then, whose direction does the program follow? Well, it depends. Some residents have chosen a decision maker, and some have been assigned to a decision maker by the courts. Other residents rely on someone who helps them make medical and financial decisions. In this section, we will explore different types of decision makers and their authority to make decisions with or on behalf of the residents. So why is this important to the LTCOP? If a resident has a supported decision maker, the LTCOP still needs permission from the resident to share information with that person. Okay, third-party decision makers. So there are two types of decision makers: those that are assigned by the resident and those who are assigned for the resident. So decision makers may only act within the guidelines granted by or for the resident. A power of attorney is a document in which a person appoints another individual to be their decision maker if and when they are no longer able to do so, or earlier in some situations. There are different types of POAs, and there are lots of misconceptions about powers granted in a POA. The definition of guardianship and conservatorship may vary from state to state. In most states, when a guardian or conservator is appointed, the court removes all or some of the individual's rights and deems the individual incapable of administering their own affairs. Those affairs may be financial or personal, day-to-day, or both. Guardianships and conservatorships may be limited in scope and in length of time. Some guardians or conservators are family or friends of the resident who knows them and their values and goals, and others are court-appointed professionals who do not know or may have never even met the resident. So the Long-Term Care Ombudsman Program advocates that the resident choose who their decision maker is and what authority they are giving to that person, as opposed to having the court make these decisions, because guardianships and conservatorships remove individuals' rights. They should be considered as the last resort. Okay, and then there are different types of POA. For example, we have a durable power of attorney that comes into effect as soon as the document is signed. A springing power of attorney, which springs into effect if the principal becomes unable to communicate informed consent. There are POAs specific to healthcare decisions and some that are specific to finances and property. Every state has their own specific power of attorney terminology and their own forms and their own laws. So again, you're going to get that information you're going to get a cheat sheet for the state of Arizona. So why is this important to LTCOP? In order for a representative to take direction from an agent under a power of attorney, the type of POA and the powers and authority granted to the agent must be identified. It is necessary for the Ombudsman program to obtain or review POA papers to determine the extent of the authority that has been granted. So, okay. And then here is just a little bit about the conservatorship and the guardianship for the Arizona Information Guardianship Conservatorship and what it says in our laws. And you can read what it says here on the slide. It says guardianships manage another person's health care, health and welfare. Conservator manages another person's finances and their assets. Person can be appointed. They can be appointed a guardian or conservator. Non-licensed fiduciaries must complete training and become a guardian and a conservator for personal representative. And that's really important that we understand that there has to be training for this. And then at the bottom here, you have surrogate decision makers, which is something that is kind of unique to Arizona for the health and welfare of the resident. Okay. Okay, representative payees. Okay, now we're going to talk a little bit about representative payees. So a representative payee is a person or an organization appointed to receive Social Security or supplemental Social Security income, what you call SSI, benefits for anyone who can't manage or direct the management of their benefits. SSI is designed to help people who are aged, blind, or have disabilities and who have little or no income. SSI provides cash to meet basic needs for food, clothing, and shelter. So, resident representative. So, does the resident have an advanced planning? So these are just sort of a checklist of things that you, as a long-term care ombudsman, want to consider. For further information, you can look at in your book, there is the long-term care ombudsman rule, and it has some information on SSI. But the long-term care ombudsman rule defines resident representative as an individual chosen by the resident to act on their behalf, or a person who is authorized by federal state law, i.e., the power of attorney, representative pay, or other fiduciaries, to act on behalf of the resident in order to support the resident in decision making, to help with access to medical, social, or other personal information of the resident, to manage finance or financial matters, or to receive notification, legal representation, or a court-appointed guardian or conservator of the resident. So when working with or on behalf of a resident, there are times when the ombudsman program takes action from the representative of the resident's representatives. Once the long-term care ombudsman has determined that the resident is not able to communicate informed consent, and before the long-term care ombudsman program takes direction from someone other than the resident, there are a few things to consider here. Okay, does the resident have an advanced planning directive? So if so, what kind of directive? Does the resident have a supported decision maker? Does the resident have a guardian or conservator? Is there evidence of the resident's representative authority? So when it comes to investigating complaints, the long-term care ombudsman rule is very clear, and it requires the ombudsman program to determine and to verify the authority of the decision maker. The rule states, and I'll quote, shall ascertain the extent of the authority that has been granted to the resident representative under court order in the case of a guardian or conservator, or by the power of attorney or other document by which the resident has granted authority to the representative under other applicable state and federal laws. So in other words, the ombudsman program reviews the relevant documentation to determine in what circumstances they are to follow the direction of the resident representative. For example, a daughter may say that she has power of attorney to make health decisions. The Ombudsman program must ask for proof and verify the accuracy and the details of that decision-making authority. And this may require the Ombudsman program to consult with the program's legal counsel or legal services. But if there's any questions or concerns, by all means, always go to your supervisor first. So you always we just kind of went under this, review the forms, always. We want to look what under circumstances, what authority, what decisions, and what rights does the resident have. Okay, section 5, we're going to talk about empowerment. So, empowerment is a primary role of the Ombudsman program, our long-term care Ombudsman program. It's a core of our program. And that is in which representatives provide the tools, which is information and about resident rights and facility responsibilities, encouragement, and assistance to promote resident advocacy by empowering residents to help them to become stronger and more confident. In an ideal world, when a resident has a concern, they feel assured to approach staff or others for help. However, there are factors that may affect a resident's sense of empowerment. So let me digress just a little bit. First of all, the Ombudsman program was created to restore the balance. You see the seesaw here. To restore the balance of power between the resident and the staff, as well as between residents and their own family members. So the long-term care Ombudsman ensures residents have someone on their side who helps empower them, and if necessary, to be their advocate. So there are barriers to empowerment, and we'll talk about that a little bit. Barriers may influence a resident's sense of empowerment, and there are several of them. Residents may feel hopeless, and they may experience physical, emotional, and psychological, social, and mental challenges that make it difficult to voice their concern. They may accept the rights violation as part of the living. They're just going along with it in the nursing facility. They may express not wanting to rock the boat. They may fear getting someone in trouble. They may feel isolated. They may not want to be labeled as a quote unquote troublemaker. They may experiencing side effects of medication that interfere with the resident's ability to voice concerns. They may feel like complaining won't help. They may not have been educated in their rights and how to assert their rights. They may be treated differently for complaining. There's that real fear of retaliation. And the staff, they may run the resident councils, resulting in residents not speaking out about their concern. The staff may not have been trained in resident rights, and the staff may be ambivalent or negative when responding to residents, and they may just ignore the concerns of their resident completely. So we're going to see a film, and this film is called The Fear of Retaliation. And then here are some questions to think about after the film. And what I'm going to do, should be a part, you should have gotten this. This is going to be sent to you in an email. So look for the email. There'll be a YouTube film that says Voices Speak Out Against Retaliation. But here are some of the questions, and we can review these. What reasons are given for not reporting poor treatment and problems with the facility? What concerns? Number 2, what concerns or fears are brought up by the resident? What examples of retaliation did you hear from the video? What examples to overcome from the fear of retaliation are discussed? So if you haven't seen the film yet, you would what you need to do is stop the recording right now and watch the film. And it's about 30 minutes or so. And then you can resume this training and then have those questions answered. Okay. So I'm assuming now, moving on, assuming that you have watched the film, so we will continue with this module, with this section. Retaliation. And the fear of retaliation is one of the most common reasons expressed by residents for not seeking resolution to their concern. Retaliation may be real or perceived, but in either situation, it is frightening to the resident. When instances of retaliation occur, they can range from subtle to obvious. Subtle instances of retaliation include call lights not being answered or delayed in being answered, staff ignoring residents for their request for help, nurses withholding pain medication or late when distributing medication. Obvious instances of retaliation include, but are not limited to, rough care, abuse of a treatment, eviction or attempted eviction or the threat of eviction, or withholding food and water. So, partnering with residents for self-advocacy. Representatives have one thing in common. They want to help residents. Often the first thought is to come to mind is to spring into action for the resident, but that's not really empowering. Empowering is the primary way to help resident and is the first tool representatives use. Explaining resident rights and encouraging residents to have direct communication with other residents, family members, and staff will improve the residents' ability to resolve their concerns. Empowerment begins with listening to the residents' concerns about and their ideas about resolving their concerns and the action they have already taken to address the problem. Listening to the resident shows them that their thoughts and their feelings are important. Some specific steps the Ombudsman program can take to encourage empowerment for self-advocacy include, but are not limited to, educating residents about their rights. Oh, I'm sorry. I kind of jumped up. Listening, and listening is the first one. And it begins with listening to the residents' concern about their ideas, resolving their concerns and actions they've already taken to address their problem. Listening to the resident shows them that their thoughts and their feelings are important. Some specific things to think about are educating, residents about their rights, including their right to grievances without fear of retaliation, educating family, decision makers, and staff about resident rights, encouraging residents to participate and address their concern and care plan need, encouraging residents to participate in addressing their concerns with resident council meetings, and talking about which staff members they may be most effective when they're addressing their problems, explaining how to file a complaint with the state survey agency and the pros and the cons for doing so. We'll talk about later on care plan meeting and resident council. They're discussed later in this model. So here's a brief film on resident rights. So when talking to a resident about their concerns, suggest the resident meet with the staff whom you both have identified as the person most likely to resolve the problem. When you make this suggestion, it may be helpful to offer to attend the meeting with the resident. The Ombudsman program's presence may increase the resident's confidence that their concern will be heard and resolved. If you attend a meeting with the resident and staff member, make sure you and the resident have a clear understanding of what will be discussed and who will take the lead in the discussion. Always go with the resident's preference. Talk to the resident about their desired outcome of the discussion so you understand the goal of the meeting. Remember, you are there to promote resident empowerment and advocate for resident rights, not to bring the resident in line with the facility's preferences. So at this point, you will go ahead and you will see the film on resident rights, which should have been sent to you in an email. You can finish that section and then return to this film. So if you haven't seen it, you could stop and pause right here, look at the film, and then return. Okay, so we are going to go on to section 6, which we're going to talk about resident assessments and care plans. So all nursing facilities are required by federal regulations to provide supports and services necessary to help residents reach or maintain their highest practical level of well-being. The nursing facilities are required to conduct an initial and periodic comprehensive and accurate assessments. The initial assessment evaluates the functional capacity and helps the staff learn about the residents and their needs. The resident assessment instrument minimum daily set, often referred to as the MDS, is the required assessment tool used in nursing facilities. It is designed to collect the minimum amount of data to guide planning and monitoring for residents. It is from this assessment that care plans are developed. The most important tools for assuring that residents receive adequate care and through the resident assessment, care plan development, and care plan meeting. When does the nursing facility assess the resident? Well, here are the times. At the time of admission, when readmitted, following hospitalization, quarterly, annually, after a significant change in condition, when a significant change or prior assessment needs to be made, and at the time of discharge. So you can see right here what I just said on the slide. So here's a note: when Medicare is paying for the resident's stay, the facility must complete an assessment at the following intervals. It has to be 5-day, 14-day, 30-day, and 90-day mark. Okay. So what is the Ombudsman role in the assessment? The Ombudsman program can help residents participate in the assessment process to the greatest extent possible by suggesting that the residents prepare for the assessment by thinking about daily routines or activity preferences and goals before the staff begins interviews. Number 2, reminding residents that they can request activities or daily routines that are not included in the list of the MBS assessment, and helping the resident work with facility staff to resolve any issues related to assessment interview procedures. The baseline, and then we're going to talk a little bit, as soon as I can get my mouse back, a little bit here about the baseline care plan. So within 48 hours of admission, nursing facilities are required to develop a baseline care plan for each resident. It must include the instructions needed to provide effective and personal-centered care of the resident and meet professional standards of quality of care. The nursing facility is required to provide the resident and their decision maker with a summary of the baseline care plan, including but not limited to the following information. It has to have the initial goals of the resident, and the summary of the resident's medication and dietary instructions, and any services and treatments to be administered by the facility. Okay, the care plan. The care plan must include resident-specific measurable objectives, a time frame to meet the resident's medical, physical, mental, and psychosocial needs identified in their MDS. The care plan must also describe services that will be used to help the resident attain or maintain their highest quality of practical, physical, mental, psychosocial well-being. Care plans must include the resident's preferences, including the right to refuse treatment and the potential for discharge. So a thorough plan is individualized. It is specific. It is comprehensive. It's written in a language that everyone can understand. It is reflective of the residents' concerns and their preferences and goals. Where am I? And it's supportive of the residents' well-being, abilities, and rights. So resident rights to participate in the development and implementation of their person-centered care plan are clear. The mere existence of the regulations, however, does not guarantee that these planning processes will operate in a person-centered way. Some nursing facilities may incline to treat the planning regulation as bothersome requirement, which makes it essential that residents effectively assert their right to participate and their preferences for care and discharge. And this is where the Ombudsman program can provide an extra voice of knowledge and support to help the resident to achieve their goals. So the residents' right to related to care planning. They have the residents have a right to participate in the care planning process, including the right to identify individuals or roles to be included, the right to request meetings, the right to even revise the person-centered care plan, the right to participate in establishing expected goals and outcomes of care, the type of care, the type of meeting, the frequency, the duration of care, any factors related to the effectiveness of the care plan. They have the right to be informed in advance of changes to the care plan. They have the right to receive services and items included in the care plan, and the right to see the care plan, including the right to sign it after significant changes to the plan have been made. So nursing facilities, they are required to inform the resident of their rights to participate in their treatment plan and to support them in doing so. The planning process is required to include the resident, the representative, the assessment of the resident's strength and their needs to incorporate in the resident's personal and cultural preferences in developing the goals of care. Once the MDS assessment is complete, the care plan is written. A care plan meeting is held no later than 21 days. Let me advance. No more than 21 days after admission, and every 3 months or after a significant change in condition, the care plan meeting is supposed to be scheduled to accommodate the resident and the resident representative. So we have 21 days, we have 3 months, and after a significant change. And again, it's meant to accommodate the resident, which doesn't always happen. Okay, so let me digress here. I'm going to go back to this slide here for a minute. The care plan meeting is a conference where the staff, the resident, the persons of the resident choice go over the care plan. Care plans are great tools when resolving a complaint. Representative of the office can participate in a care plan meeting with the permission of the resident. It is a good idea that to request a care plan as well as a proposed care plan prior to the meeting, both care plans with the resident, and talk about the residents' concerns and their goals and expectations of the residents' role during the care plan meeting. While an effective care plan requires the involvement of several individuals, all members of the care plan team may not actually attend the meeting. Then we have person-centered planning in home and community-based services. So as mentioned earlier, CMS published in a rule in 2014 that defined home and community-based services for services states that provide HCBS waivers. The rule explains that what the states must do in their Medicaid HCBS programs by establishing rights for HCBS recipients and requirements for service providers. The HCBS rule applies to all settings in which the HCBS recipient lives and receives HCBS services, including residential care communities that accept Medicaid coverage for services. The rule describes the minimum requirements for person-centered care plans developed through the process, including the process that results in the person-centered plan individually and identified the goals. So similar to federal nursing facility requirements for assessments and care planning, the HCBS rule requires the development of a person-centered service plan that is developed using a person-centered planning process driven by the individual receiving the services. The rule includes 4 main steps. Number 1, an assessment of the individual and what they need. Let me see if I need to. Number 2, person-centered care plan meetings. Number 3, writing a plan. Number 4, reviewing the plan. Okay, so they have to have those 4 things. All right, so our next is a person-centered care plan. This is a video that is an introduction to care plans and the care plan process. So if you have not yet, you can stop the video right here or I'll stop the presentation or come back to it. Watch the film, Person-Centered Care Plans, which was sent to you in an email, and then we can resume the film. There are 4 questions to ask. I'm sorry, there's 2. What key points does the video explain? So please write that down. And number 2, have you participated in a care plan meeting? So go ahead, if you haven't yet, watch the film, and then we can resume the training here. Okay, there are some key care plan participants for having this meeting. So we have the resident's legal representative, we have care plan coordinator, physician, nursing, dietary, therapy, social services, activities, anyone else invited. That can be a hospice nurse, that can be a family member, that can be us, that can be an ombudsman. So what is discussed at these meetings? Okay, so residents' needs and preferences, the supports and services provided, the staff responsible for providing the services, the residents' preferred daily routines, the dietary preferences and concerns and needs, the residents' preferred activities and interests and medications, and the desire to leave the facility and return to the community. So now I do have a question. In the film, how did Mrs. Durham treated as a partner in the care plan? So we're referring back to the film, if you can remember, how was she treated in this film? And so write that down. How was she treated? How did the staff treat her? So just something to think about. Okay, the ombudsman preparing, we want the ombudsman program advocacy before, during, and after the care plan meeting. So preparing for the care plan, that is one of the things that we really want to get into. Prior to the meeting, many decisions have already been made in terms of care needs, goals, and interventions. So meetings tend to be back to back. They move into about 15-minute intervals. However, nursing facilities are required to hold the care plan meeting at a time that it is convenient for the resident when the resident is functioning at their best, and also to provide sufficient notice in advance for the meeting and a schedule to meetings to accommodate their representative. This could be a family member. So such as conducting the meeting in person, or if they need to set up a video conferencing call, maybe the person has, wants to have it on their lunch break or something, the POA, their daughter, their son, adult son. So they're to accommodate, to make this as convenient and easy for the resident as possible. Doesn't always happen. So if this doesn't happen, is there sufficient time? Are they doing this? Then what needs to happen? Speak up. We need to encourage our residents to speak up if they're not getting the quality time for their care plan meetings that they need. Okay, so being prepared. The ombudsman program can empower the resident and their decision makers to speak up if they would like the meeting to be longer than the scheduled time frame, or prefer or need the meeting to be on a different day. They need to speak up. The long-term care ombudsman program can also offer to attend the meeting if the resident would like the person, representative, to be there. And also if the resident would like the long-term care to attend to talk about the resident's expectations, the long-term care ombudsman program's role, and the care plan meeting, as well as the resident's concern and their goals. The representative can empower the resident by suggesting they prepare a list of assistance, activities, or other preferences that the resident wants to have included in the care plan. Also, ask the resident to think about how those preferences should be explained or presented to the nursing facility staff. The resident and their families likely will be unfamiliar with the care planning process, so at least at first. So it may be a good idea to have some good preparation. It's important. This way it ensures that the care planning process is properly focused on the residents' needs, goals, and their preferences. So the long-term care ombudsman program advocacy during the care plan meeting includes the resident has an opportunity to speak, the resident's questions are being answered, the resident's preferences are addressed, supports and services and options are discussed, the resident understands and agrees with the care plan, the resident receives a copy of the plan if requested, and the resident knows who to talk to if there are changes to be made in the care plan. The resident must understand that there are options to leaving the nursing facility and receive long-term services and supports in the community, and to seek out assistance if this is applicable. So transitioning to the community is discussed in a future module. Okay. So after the care plan meeting, the long-term care ombudsman program actions may include, but are not limited to, following up with the resident to find out if the care plan is being followed, and asking if the resident is satisfied with the supports and services received, and asking if the resident, if changes need to be made to the care plan, explaining the resident right to request a care plan meeting at any time to make modifications if the change is not included in the care plan. It is not likely to happen. Very important thing to understand. Okay, so moving along, we're going to talk about our the next section here, which will be resident councils and family councils. So, resident council is an independent group of residents living in the same facility who meet on a regular basis to discuss and seek resolution concerns, develop suggestions to improve the life of the facility, and the plan activities to promote socialization with other residents. Some states have regulations pertaining to resident councils in both nursing facilities and RCCC. States regulations often mirror the federal regulations. So federal regulation, home regulations include the following requirements for resident council. The facility must include a resident council if one exists with a private space for a meeting. The facility must take reasonable steps with the approval of the resident council to make residents aware of upcoming meetings in a timely manner. The facility must provide a designated staff person who is approved by the resident council and the facility to provide assistance and respond to written requests from the council. The facility must consider the views of the resident council and act promptly upon grievances and recommendations of the resident council concerning issues of resident care and life in the facility. And the facility must be able to demonstrate their response and their rationale for their response. The right to respond does not mean facilities are required to implement every request of the resident council. For example, if they want a flat screen television, a $5,000 flat screen television, and the facility has a right to say, that's not really in our budget to do that. So it has to be realistic. The resident council meetings are closed to staff, visitors, and other guests. For staff, visitors, and other guests to attend, the resident council must invite them. So the Ombudsman program is required to assist with the development of the resident council when representatives often encourage the residents to share their concerns during the resident council meetings to address concerns that may affect all or some of the residents, such as call lights not being answered and food being cold, that sort of thing. Representatives of the office must have the approval of the council members to attend the meetings. Often the representatives are welcome to attend and do so on a regular basis. There are great benefits to attending the resident council meetings, such as getting to know residents, being familiar with the residents, and getting to know how they're being treated, how the facility is being managed, and understanding the culture of that resident council and the environment. So it's a good idea to check into the resident council president and another council member during regular visits to get a sense of what's going on in the facility. So the next one is a family council. The family council is a group of resident family members that meet regularly to discuss and offer suggestions about facility policies and procedures affecting resident care, treatment, and quality of life, support of each other. They plan resident and family activities. They participate in educational activities or for any other purpose. Members form a united consumer voice, which can play a crucial role in voicing concerns, requesting improvements, supporting new family members and residents, supporting family efforts to make sure to take care of life in the facility and make sure it's the best it can be. Similar to how parent PTA works, family councils provide a way for concerned persons to actively participate in helping the facility to be the best it can be through combining and prioritizing shared concerns and then communicating them to facility administrators, making recommendations, suggesting solutions, sharing answers and information. When replies are received and supplementing staff services via additional actions which enhance resident life. So Family Council meets regularly and promotes communication, action, support, and education. The specific activities of the council depend upon the needs of the residents and the choices made by the council members. Family Council operate on the premise that there is strength in numbers and that combined voices garner more attention than just one. Increased family involvement fosters greater staff accountability, which in turn decreases the possibility of neglect and abuse. So streamlining concerns is more efficient and reduces time staff ultimately spend addressing repeated issues. In 1987, the Nursing Home Reform Act guarantees families of nursing facility residents a number of important rights to enhance a loved one's nursing facility experience and improve facility rights, services, and conditions. Key among these is the right to form a family council and to hold regular private meetings. Nursing facilities, must provide a meeting space, cooperate with council activities, and respond to groups concerned. Nursing facilities must appoint a staff advisor or a liaison to the family council, but staff and administrators have access to council meetings only by invitation. So while the federal law specifically refers to families of residents, close friends, or of residents are encouraged to play an active role in family councils too. So specifically, the federal law includes the following requirements. A resident family has the right to meet in the facility with the families of other residents in the facility. Facility must provide a family group if one exists in the private space. Staff or visitors may attend meetings at the group's invitation. The facility must provide a designated staff person responsible for providing assistance and responding to written requests that results from group meetings. When a family group exists, the facility must listen to the views and act upon the grievances and recommendations of the residents and families concerning the proposed policies and operational decisions affecting resident care and life in the facility. These federal requirements are often supplemented by state statute as well. Okay. So, Ombudsman program and family councils, in addition to acting as advocates for residents, Ombudsman program can educate residents and families and friends about resident rights and state surveys and federal and state laws that are applicable to nursing facilities and other long-term care facilities. The long-term care Ombudsman program also provides support and advocacy to family councils when they are asked. Successful family councils maintain open communication with the long-term care Ombudsman program, which is mutually benefit. The program is kept informed of concerns which reflect multiple resident experience, which often reflects the facility culture. And the council has a human resource that can help to differentiate between fiction and which members to seek to clarify and correct the problem. Okay, so even if a state does not have regulations for residential care communities regarding resident councils or family councils, there are no requirements restricting the council and the Ombudsman program to provide support for councils in RCCs as well. Okay. So this is the conclusion of our module 3. There's a few questions to ask. They're also in your manual. Why is it important for the representatives to know about the advanced planning and third-party decision? Number 2, explain what empowerment means to you. Number 3, when a resident is hesitant to speak up about a concern, what can you do to help? Number 4, name 4 residential rights. And number 5, name 2 things that a facility must do to assist the resident council and family councils. True or false? Okay, the charge nurse is responsible for assuming that the nursing care provided by the other nurses and nurses aid meet federal state requirements. And you can see there the answer is false, gives us the answers. B, the care plan coordinator is a social worker who works with other facility residents and resident family members to conduct assessments to coordinate individual family care. And that too is false. It's already on the slide. So any questions or concerns, please reach out to the trainer, me, Danielle Sanders, and I'll be happy to answer those questions. And thank you for participating and watching and learning as we are going through this 10-module program. This was module 3, and we will proceed with module 4 for a live presentation on Google Meets. Thank you.